I think we should now proceed coming to the visible lesions. So Art Rastinehad from the Smith Institute for Urology, everyone knows you, but anyhow, so please start with the fusion-guided treatment of the visible lesion.
Oh, thank goodness. But I think we should spend a lot of time discussing that during the coffee break while we see the vendors, because this is an unmet need in our space and we all are kind of fighting over these things. And we're also sometimes interpreting the data that we publish in incorrect ways and coming to the wrong conclusion. So I think there's a lot of areas for improvement. I'll be talking about MR ultrasound-guided fusion treatments. Welcome to the future. These are some of my disclosures. They do overlap with today's talk. There's a lot of factors that go into planning for focal therapy. And today I'm going to be touching on the ones that I think are really important for us to understand with respect to targeting and using these different modalities. We always look at the type of biopsy that was done. Of course, we just discussed that a radiologist that wears a blindfold or has no skills has negative MRIs more often than someone like Baris Turkbay. The CAD AI systems that we're using today hopefully augment some of these limitations are important, and what platform do you use to deliver the energy of your modality? I'm not going to get in the type of modality that it is. When we were at the FDA early on, the FDA looks at prostate cancer like the chicken nugget of prostate cancer, because we freeze it, we fry it, we steam it, we microwave it, we electrocute it, we stuff it, and we cook it. And this is the challenge with our group today, is what's the best modality going forward, and we're not here to discuss that, but it's probably the one you're most comfortable with. And then, what really plays the largest role in our outcomes of our patients in focal therapy? As we just discussed, MRI invisible tumors, I really believe its suboptimal interpretation as well as image acquisition play a major role, and not the biology of the disease so much so with respect to the interpretation of the data. The fusion biopsy data, are you doing things with cognitive biopsy? Was the biopsy done transperineal or transrectal? And was fusion used? I think this is important. And last night at dinner, we really came, and the board meeting, Dr. Emberton spoke up, is the FTS and our group is really focused on the risk stratification as our key factor moving forward to push the field of focal therapy. Because if we can't risk stratify, which we just struggled with the talks of the two speakers before, if we can't do that, we can't identify the tumors, how are we expected to have good outcomes with focal therapy? As we looked at focal therapy, we're gaining parity with prostatectomy at 8 years. That's exciting stuff, but I think you have to realize that all of you that have been coming for the last 15 meetings, it's about risk stratification and identification of the tumor to treat it. I always put this slide up. How good is your neighborhood MRI center? These are 3 prior papers on the right side of the screen, and this is one of our MRIs from a research study. If you can't identify the individual stromal nodules, you can't see the surgical capsule or the capsule of the prostate, you are missing out on the opportunities to visualize and identify prostate cancer. If you look on the slide, you can see by the arrow in the middle slide, that's a T2 image. The yellow arrow, you see how you can see the prostate cancer moving through the peripheral zone, and you clearly understand that we can underestimate. Depends on the modality you look at. Clearly, compared to the ADC, it's a much larger lesion on the T2. This is probably the best MRI I've ever seen, so I am biased. This was a research study with a coil. Thanks, Baris. So just so you guys know, Baris and I was a fellow with him and basically helped me launch the entire focal therapy program and imaging at our institution when I got out of fellowship. So I'm grateful for his help. Let's get started on my talk. We're going to visualize the steps on how we plan for focal therapy and a hands-on description. I'm going to kind of talk our way through a bunch of cases. This is an example of path review. If you're not doing this before focal therapy, you will have a higher failure rate. We visualize the cores on the MRI. This patient may have had a biopsy before, and now we're going to move his cores in 3D into the current MRI and determine where we can best plan a margin. Right now we're co-registering the MRI from one and the other, and now I'm able to put the needles in 3D space overlaying my prostate MRI. I think this is really key in understanding perilesional biopsy. When I do a focal therapy, always be planning. ABP, like the restaurant. You're putting a core where you think is the edge of where your margin's going to be when you're doing it, if he's a candidate for focal therapy, so you can better understand. In this example, there's a lateral core and it was not visualized. and it was negative for cancer in the planning. Review the biopsy. These are the screen captures. Every fusion system does it. If you're not reviewing the biopsy and checking your co-registration, you're going to have errors. You can also tell if someone didn't plan the procedure correctly. And this is a static image. So someone can lie in a static image. And now we record all our cases at our institution. So there's a video uploaded to a central server. So one of my partners or someone has a question, a difficulty, I can see every single step of the case. And I think this keeps people honest. It also helps people learn. And you can understand, is this patient going to be a good candidate for focal therapy? Was everything done appropriately? And was it sampled? And are the cores actually where they're supposed to be? Because sometimes you have core registration that has an error. It's misregistered. And now this can help avoid those basic mistakes when planning. So here's the classic ablation zone planning. This is painful. You have to draw, measure what your margin is. This is a 5 to 6 millimeter margin in all 3 directions around your lesion. Then you visually draw an ROI around the space. Now, the most common error that I see when people have failure from focal therapy is not in the XY plane or the axial plane. It's in the Z axis. And it's because you're not considering the direction of the tumor and how you're treating the Z axis. If you're treating transperineally, you're going to miss the apex and the base side of your lesion if you don't put a large enough margin on it. Also, you have respiratory variation during your procedure. The prostate moving back and forth is in the Z axis, that apex to base, and you can miss the area. So this is the old way we do it. I spent hundreds of hours doing this. Now, we just click, name our margin, say how big we want it, boom. And you can see in the coronal screen below, in the Z axis, we have a margin above and below. You have to remember that your MRI most likely or should have the 3 millimeter T2 axial thickness. If it's not PI-qual compliant, and it's suboptimal for fusion. So you should understand this and notice that I put the margin on. You see the Z axis above and below. A lot of people would underestimate that distance for fusion and treatment. Now, we do advanced annotation of treatment plan. You can sit in your office, you set what your distance you want between the probes are. Do you want to pull back or not? And it can compute the plan by itself, or you can manually do it yourself here. So you can see the red circle coming up on the screen, overlaying the 3D map of the prostate. How can I cover this? Which probes am I going to use? And you can see I picked the location. Can I fit this in there? And this can be done with any modality. This is an example for cryotherapy, but IRE, nano, any transperineal, as well as it works with HIFU too to work out your ablation zone, because I'm going to show you how you can output the information to HIFU systems as well. I used to think this was kind of silly. I was like, I can read an MRI, I don't need this. After using this during the trial, I almost always prefer it because it takes the thinking out of what you have to do. You don't have to keep everything in your head in 3D space, what I'm treating, how am I going to have a layout, what's happening during the case. This is what it used to look like. We have our fusion in the upper left, our lesion, our margin, and how are we going to treat the area. And this is just an example of fusion with cryo. You stick your needle in. This is basic fusion. Every company has 510(k) clearance now off the original Euronav device for ablation guidance with fusion biopsy in the US. And you're able to see how far you push the ice. The ice is not pushed far enough yet in the picture, but it's for visual representation. Now, automated planning, the future. This is research. You just hit the button, it spaces it out. You know where to put the probes, and you can modify this as you like. It's much faster. You can change your angle of attack. You can see where the pubic bone is. Is it going to be in the way or not for your planning? This is just, it's replaying. You see how easy that was compared to manually doing it, and well as really manually doing it, drawing it on the MRI. Surgical navigation. This is what we took from, we did a study at Sinai when I was there. We looked at if we took the 3D information in and pumped that into the robot, and you can see a 3D map of the pelvis, would this improve your margin status? We showed a decrease of margins by 50%. That was pretty significant at a low-cost solution of just piping this in to the MRI. We're currently running a study at Northwell, and it's just exciting. And most of the people next door don't spend as much time as we do reading MRIs. And I think that's really important and improves the outcomes of our surgeries. How well does this improve? Well, this was the study from the NYU group. They had an 83.3% success rate with ablation with fusion. They did quote 90+% in their paper that they imputed the last half of their data. But this is still pretty impressive compared to where we used to be, which was around 70% when we were doing cognitive ablations in the past. Our series from the trial that we ran using the technology, we had a 93% success rate with a negative biopsy at 6 months or 12 months for clinically significant prostate cancer. My fellow Ale Marquis put this together for us, and I appreciate it. But you have to understand, there was 2 operators in the group. One was me, and one was someone with 0 focal therapy experience before the trial started. So I think that's the most profound part of this, is the learning curve is much shorter now because all the mistakes we used to make by trying to do cognitive approaches, estimating where the lesion was in ultrasound, because clearly when you have an MRI, the angle of attack does change in how you're approaching the prostate transperineally versus how the MRI image was acquired. And my last tip, if you're doing focal, remember that if it's transperineal, the probe should be pointing down at a slight angle when you place it in the rectum. It's towards the coccyx. The rectum is not parallel to the floor. You're causing significant deformation when you approach for a transperineal case. And I really appreciate everyone's time to allowing me to speak today, and the organizing committee for inviting me to speak. Thank you very much.